Test. Test. Well, it's time to begin. I hope you guys had a great Thanksgiving. So welcome back, everyone. So the rest of chapter 21 was recorded over the Thanksgiving break. We have 4 days of lecture left and a lot to do. So let's just go ahead and get started with the diseases of the respiratory system. After I have a word of prayer. Father, thank you for this snowy day. We thank you for a week off. We pray now that you would come to us and help us finish strongly. Thank you for this semester that we got as far as we did. We pray for our state, for our nation, for those who lead us. Help them lead wisely. We pray that we get this pandemic under control, that the new cases that may very well result because of travel would not be huge numbers of cases. May they be manageable. We pray for those who take care of those who are sick. Give them the skill, the will, the energy to work long hours. And now, Lord, help us learn about respiratory diseases. In Jesus' name, amen. All right. So very quickly, the respiratory system is broken into 2 main anatomical levels. The upper and the lower respiratory tract. The upper respiratory tract is largely the conductive system. So the conductive system consists of the oral cavity, buccal cavity, pharynx, larynx, the trachea, the right and the left bronchus, primary, secondary bronchi. Those are largely elements of the conductive zone. Infections of the conductive zone, which include things like pharyngitis, laryngitis, epiglottitis, things like that, bronchitis, those are all respiratory tract infections. Infections of the respiratory zone, the respiratory bronchioles and the alveoli, that would also include infections of the pleural membranes and things like that, are lower respiratory infections. Other infections that are respiratory infections because they're extensions of the respiratory system would include the sinuses, the paranasal sinuses, so rhinosinusitis, also the ears because of the connection via the eustachian tubes. So that would include middle ear infections or otitis media, external ear infections, or otitis externa. Granted, they're not connected to the respiratory system, strictly speaking, but you cover ear infections usually in respiratory infections as well. So otitis externa, and then also mastoiditis as well. Largely because mastoiditis is part of that ear, nose, throat group of infections. So it's included in respiratory infections as well. So we'll cover upper respiratory tract infections first, then the lower respiratory tract infections later. Different organisms tend to cause upper and lower respiratory tract infections. There are overlaps between them, but certain infections specialize in infecting the lower respiratory tract. Others specialize in the upper respiratory tract. The microflora of these two tracts will also differ. The lower respiratory tract is supposed to be largely sterile. The upper respiratory tract has a particular normal flora. That normal flora is quite important for competitive exclusion. And for this reason, long-term antibiotic treatment will tend to predispose you to certain types of respiratory tract infections. Okay, many types of upper respiratory tract infections will be seen in children, and many of these will be affected by mechanical obstruction, but you can also have inflammation in these areas. So if we start, for example, with some sort of upper respiratory tract, say, obstruction, then children can begin coughing, gagging, choking, drooling, and on auscultation, that is, when you use your stethoscope, you will hear inspiratory stridor. If there's complete obstruction, children might be unable to cough, might be unable to speak, and they might even pass out, at which case you start to begin your BLS, basic life-saving maneuvers, to relieve that obstruction. In infants less than a year of age, you're going to deliver 5 blows to the back, followed by 5 chest thrusts. And chest thrusts, remember, on infants, you do typically with your fingers. For children 1 year of age or older, you're going to do 5 abdominal thrusts or Heimlich maneuvers. And if the child is stable, then you do a chest x-ray. And so objects like coins or batteries are radio opaque and are visible. whereas pieces of food will be radiolucent and they won't show up on an X-ray. If an object gets lodged in the nose, you'll usually have epistaxis or nose bleeding. That's epistaxis. And you'll visualize that with a headlamp and a nasal speculum. All right, so the nose, if the nose gets infected, so you have some sort of rhinosinusitis. If it's caused by allergies and you have a rhinitis, so it's non-infectious, so if it's triggered by dust or mites or pet dander or pollen or tobacco smoke, cold or dry air, emotional stress, even exercise. Then there's nasal congestion, sneezing, and sniffling. With the so-called allergic salute. Allergic salute. That occurs when a child wipes their nose upwards, and that creates a line or a crease under the nasal bridge. There's usually also conjunctivitis. In cases like this, the nasal exudate will be watery and usually clear. This can also be caused by viruses. So rhinovirus can cause rhinitis. So can influenza virus. So can respiratory syncytial virus, parainfluenza virus, or adenovirus. Rhinitis less commonly can be caused by bacteria. 90% of rhinitis cases, over 90% of rhinitis cases are caused by viruses. If the bacteria do cause it, your culprits will usually be Streptococcus pneumoniae, Haemophilus influenzae. Now, a word about Haemophilus influenzae. The vaccination you get is Hib. So that's against Haemophilus influenzae type B. The Hib B is against a capsular antigen. There are what are called untypable Haemophilus influenzae. They're untypable because they don't have a capsule. So just because you have been vaccinated for Hib B does not mean you're incapable of getting a Haemophilus influenzae infection. If you get one, it's usually going to be the untypable ones because the vaccine doesn't prevent against the untypable Haemophilus influenzae. Okay, the other will be Moraxella, Cataralis, or our old friend Staphylococcus aureus. So this is a gram-positive coccus. This is a gram-negative, very short coccus. So it's Coccobacillus. This is, of course, a gram-positive coccus. This is a gram-negative coccus. These will tend to be in pairs. These will tend to be in grape-like clusters. These tend to be just kind of clumps of cells. Now, if your child is immunocompromised, they're a childhood cancer patient, they have a genetic disease like chronic granulomatous disease, or they have acute leukemia, then rhinitis or rhinosinusitis can be caused by the fungus Aspergillus. And this fungus grows, you have a hyphae that makes a head, and then you get these conidia, microconidia, that are formed. These conidia are these spores. And so this cluster of spores forms a head on the fungus, and the end of the hyphae looks like an aspergillum, which is the little drum-like thing that the Catholic priest uses to sprinkle holy water. That's where it gets the name aspergillus. Now, keep in mind that at birth, the only sinuses present are the ethmoid sinuses. The maxillary sinuses will form between a month to 1 year of age, and on an X-ray, it'll be hard to see them because they're full of teeth. And then the sphenoid sinuses, they develop between 1 to 2 years of age. And then the frontal sinuses, they only develop after age 10. So it's not very common for babies to get sinusitis because they don't really have sinuses yet. So in the case of a bacterial rhinitis, you'll usually have a low-grade fever. The case study I gave you, that fever is different. That fever is not a low-grade fever, that's more high-grade fever. Usually you'll have loss of appetite. So that's a question you want to ask your parent. How's your kid eating? Congestion, sneezing, and then nasal discharge. For a few days. Now, if it's a rhinosinusitis, then you will tend to have a high fever, nasal discharge, that lasts for more than 10 days. Also, some sort of voice change. That's due to the fact that the little tiny echo chambers that are our paranasal sinus, they get clogged with mucus or pus. Sometimes a facial X-ray or CT scan will visualize cloudy sinuses, that are filled with fluid or air. So viral rhinitis will resolve on its own. Your child might be miserable, but this is usually just resolved with rest, fluids, and usually with nasal irrigation. Let me say a word about nasal irrigation. You've got all kinds of garbage on the web that says to wash your kids' nostrils out with baby shampoo. Don't put anything up the nose except sterile saline. There are sterile saline washes you can buy over the counter. Don't use shampoo or anything in the nose unless you are told to by your doctor. That's really important. For bacterial rhinosinusitis, the drug of choice is Augmentin. So oral Augmentin, the adult dose for Augmentin is 875 mg per course. Your pediatric dose is going to be 22.5 mgs per kilogram body weight. That's your pediatric dose. And this is taken twice a day, and you treat for 10 days. More and more people are treating for 7 days, and we're seeing more treatment failure. So the standard still usually is to treat for 10 days, or, well, let's say 7 to 10 days. If you have an individual who gets an Aspergillus infection, this, first of all, will require surgical debridement. They need usually IV antifungals. So these may include the echinocandins, or for Aspergillus, the azole of choice is voriconazole. Amphotericin B is only used if this gets disseminated to the meninges or something like that. Any questions on rhinitis or rhinosinusitis or something like that? All right, now some pathogens can bypass the nose altogether and just attack the pharynx. Some will attack the pharynx by traveling from the nose down to the pharynx. So rhinovirus and then your beta coronaviruses will basically infect the pharynx in that fashion. Streptococcus pyogenes, group A streptococci, they will essentially bypass the nose altogether and will affect the tonsils and pharynx in general, as you can see here in these pictures, causing a pharyngitis. Streptococcus pyogenes and streptococcal pharyngitis are responsible for probably half your visits to your family clinics. Walk-in clinics, family clinics, up to 50% of their visits are for group A streptococcal pharyngitis. So how do you tell the difference between a viral tonsillopharyngitis and a bacterial tonsillopharyngitis? First thing, the bacterial tonsillopharyngitis is rare in children under 3. It's more common between the ages of 3 and 14. So the viral tonsillar pharyngitis causes a low-grade fever, sore throat, vocal hoarseness, and then many symptoms of the common cold. Nasal congestion, conjunctivitis, cough, stuff like that. On a physical exam, as you can see here, there's erythema and edema of the tonsils, but no exudates. Let me emphasize that. No exudates. This pus that you see on the tonsil here, you don't tend to see that in viral tonsillopharyngitis. That's more the case with bacterial tonsillopharyngitis. You will have a non-tender anterior cervical lymphadenopathy. So if you feel the tonsils, and if you lift your chin like this, you get your fingers in here and you feel, you can probably feel your tonsils. And they're not very big. Now, if they're big, that means they're inflamed. Strep throat, on the other hand, or pharyngitis caused by Streptococcus pyogenes, will cause a high-grade fever, sore throat, voice hoarseness, and you won't have the symptoms of the common cold. You won't have the symptoms of the common cold. You'll have erythema and edema of the pharynx with gray-white exudates that cover the pharynx and the tonsillar pillars. And then you'll have the anterior cervical lymphadenopathy. So to identify strep throat, use the center criteria. So center stands for, so C means can't cough. So there's no cough. E stands for exudates. Exudates around the tonsils. N stands for tender lymph nodes. T stands for a temperature that's higher than 38 degrees centigrade. That would be 100.4 Fahrenheit. And then OR stands for age, between 3 to 14. If your individual is between 3 to 14, they get 1 point. If they're between 15 and 44, they get 0 points. And if they are above 44, they get -1 points. So if you score these, each one gets a point. If the score is between -1 to +1, the risk of strep throat is negligible. If the risk is between 2 and 3, then the risk is higher, and you do a rapid antigen detection test. This is the kind of test we did in the lab. This is a quick strep test. If the score is 4 or higher, the risk of strep is very high. You essentially just start treatment. Now, sometimes if the bacterial infection, this is in children over 10, if the infection forms in the peritonsillar space, then you can have a peritonsillar abscess. It usually forms behind the posterior pharyngeal wall. Then it could be called a retropharyngeal abscess. In both situations, you have a high fever You have drooling, and then dysphagia, that's difficulty swallowing. You also have so-called londinophagia. That simply means chewing is painful, and you have a muffled voice. It's sometimes called a hot potato voice because it's someone is talking as though they have a hot potato in their mouth. There may also be difficulty opening the mouth, so-called trismus. And then that's more the case in the peritonsillar. Whereas in a retroperitoneal, you'll have a stiff neck. Or torticollis, retropharyngeal abscess there. And on a physical exam, the tonsil will be enlarged so big it's going to shift the uvula. The tonsil will actually get so big the uvula is going to shift to one side. So it looks like a bulge in the wall of the pharyngeal, the bulge in the pharyngeal wall. So a CT scan can confirm the abscess. These need to be drained with an incision. Abscesses in general, you have to drain them. And then you usually treat with either clindamycin or augmentin. Augmentin, I gave you the dose earlier. I won't repeat that. Clindamycin, the adult dose of clindamycin is usually 300 milligrams twice a day. For children, yeah, children, it's 10 milligrams per kilogram body weight. And clindamycin will be 3 times a day. That's TID. Whereas this will be 45 mg per kilogram, and that will be BID. That's for your peritonsillar abscess. All right. So laryngitis and epiglottitis. Laryngitis, the most common cause are viral infections. They spread down the trachea and the bronchi. And if you have laryngotracheal bronchitis, that is commonly known as croup. Croup. C-R-O-U-P. Croup. Croup will typically occur In children between 6 months to 3 years of age, it's classically caused by parainfluenza virus. It can also be caused by influenza itself or respiratory syncytial virus or adenovirus. You usually have a prodrome that consists of fever and nasal congestion, followed by a barking cough that kind of sounds like an angry sea lion, combined with a hoarse voice and inspiratory stridor. If you do an x-ray of the neck, you get this subglottal narrowing that is in the x-ray looks a little bit like a church steeple, so it's called the steeple sign. The steeple sign. Croup is assessed by the so-called Wesley-Croup score, the Wesley-Croup score. And there's 5 parameters, each of which gets a 0 to 5 points. So the top score you can have is 25. And they grade the severity of the stridor, chest wall retractions, the diminishment of air entry, cyanosis, and the diminished level of consciousness. So if you have a total score of 2 or less, that's very mild. If you have a score of 3 to 7 on the Wesley-Croup score, that's moderate. 8 to 11 is severe, and 12 or higher suggest imminent respiratory failure. So croup is usually treated at home by giving antipyretics and giving the child cool, humidified air to breathe. I have to emphasize humidified because dry air can be irritating to an inflamed respiratory tract. A single dose of oral steroids can reduce airway swelling. Dexamethasone is the steroid of choice usually. In the emergency room, children with croup are usually also treated with inhaled epinephrine, which will reduce airway swelling. If the child improves in 4 hours, hospitalization then is usually needed. If there's impending risk of respiratory failure, then you have to take the child to the ICU. And there they'll be given repeated doses of epinephrine. There's also IV or IM dexamethasone, and the child may need to be intubated. Bacterial laryngitis is caused by either group A streptococcus, Streptococcus pneumoniae, or Haemophilus influenzae. Haemophilus influenzae has a specific preference for the larynx and the epiglottis, which tends to occur in young children, but with the vaccine, rates of epiglottitis in children have diminished greatly. Bacterial epiglottitis will cause a high fever, a sore throat, hot potato voice, and severe respiratory distress. The child may so-called tripod. That means they lean forward on their arms to get their airway open. And if a lateral neck x-ray is done, the epiglottis will be swollen, and that's called a thumbprint sign. Thumbprint sign. Epiglottitis can be a serious medical emergency, in which case intubation might be required right away. Once the airway is secure, you treat with usually third-generation cephalosporins like ceftriaxone or cefotaxime. And if the infection is caused by gram-positive bacteria, you may need to include vancomycin as a treatment as well. Okay, bronchitis. Keep in mind with bronchitis, the majority of cases are viral. Because of that, antibiotics are not a main treatment for bronchitis anymore, just because so many cases, well over 90% of cases, are viral. So symptomatic treatment, rest, antitussives, bronchodilators. Now, if you have acute exacerbation of chronic bronchitis, those are usually bacterial. So this will be characterized by increased dyspnea, increased sputum volume, and increased sputum prevalence. And now these are usually caused by sometimes mycoplasma, sometimes Chlamydophila pneumoniae, sometimes enteric bacteria, more commonly Moraxella catarrhalis, Streptococcus pneumoniae, Haemophilus influenzae, occasionally Pseudomonas. So this is usually treated on an outpatient basis. Treatment of choice because you want to hit the potential of mycoplasma, usually a Z-Pak, azithromycin. So 500 milligrams the first day, then 250 milligrams for the next 4 days. Or doxycycline 100 milligrams twice a day. You usually treat for 3 to 10 days unless otherwise directed. If you have an inpatient situation, then you use specialized antibiotics and you almost always get a culture. Okay, time for our break. We'll go ahead, take 5 minutes, and then we'll come back and talk about diphtheria. right, it's time to get back in the saddle. Now, in the pre-vaccine era, diphtheria was a major cause of morbidity and mortality worldwide. It affected primarily children under the age of 15. Until the beginning of the 20th century, as many as 10% of American children developed clinical diphtheria, and a significant number of those children died from its complication. The case fatality rate was maybe 5 to 10%. By adolescence, some 70 to 80% of the urban population was immune to diphtheria by virtue of natural infection. During the 1930s and 40s, diphtheria was eliminated, at least in resource-rich countries, following the introduction of routine childhood vaccination. And the vaccination was with the toxoid, a weakened form of the diphtheria toxin. So as the population becomes immune, you have fewer and fewer cases. You do have outbreaks, however, in resource-poor countries. So in the former Soviet Union, for example, there was an epidemic spread of diphtheria in the 1990s. Between 1990 and 1998, more than 80% of all cases in the world were reported from the former Soviet Union. There were 157,000 cases registered with the WHO, and of those, there were 5,000 deaths. Very simply, there were shortages of vaccines, shortages of antitoxins, shortages of antibiotics, and consequently, diphtheria remains a serious disease in places of the world. It's endemic in parts of Africa, Algeria, Egypt, Brazil, Colombia, Dominican Republic, Ecuador, Haiti, Paraguay, so on and so forth. And mass vaccination campaigns really haven't worked out well to get rid of it. Diphtheria is caused by Clostridium diphtheriae, in particular, strains of Clostridium diphtheriae that make the diphtheria toxin. The toxin is encoded by a phage that infects the Corynebacterium diphtheriae. So this is a case of transduction. You have a lysogenic phage, the so-called beta phage. The beta phage, when they infect the Corynebacterium diphtheriae, they confer upon it the ability to make this very, very powerful diphtheria toxin. So diphtheria toxin binds to cells. It has two fragments, an A fragment and a B fragment. The B fragment binds to the surface of the cell. It binds the heparin binding epidermal growth factor receptor. So it's a growth factor receptor that lots of cells in the upper respiratory tract have. When it gets into the cell, it inactivates protein synthesis because the A fragment is an enzyme that inactivates a key component of protein synthesis. So protein synthesis inside cells affected by the toxin shuts down. Therefore, the cells die. So a characteristic feature of this disease is the production of a so-called pseudomembrane. Pseudomembrane. So symptoms begin 2 to 5 days after infection. The earliest finding is mild erythema of the throat. It progresses to isolated spots of gray and white exudate. And then local elaboration of the toxin induces the formation of a pseudomembrane that you see here, right there. This consists of necrotic fibrin, leukocytes, erythrocytes, epithelial cells, and the bacteria as well. It adheres tightly to tissues, and if you scrape it off, the tissue underneath will bleed. This is characteristic of diphtheria. Not very many other things will cause a pseudomembrane quite like what you see with diphtheria. So if you see this, and if you do medicine overseas, this is what you're looking for. If you have an immigrant who comes in, they were not vaccinated, particularly if the immigrant is a child, they have a sore throat, you see this, it's diphtheria. It's diphtheria. The toxin can be absorbed and can damage the heart, nervous system, and kidneys as well. There's also a cutaneous form of the disease that usually results in skin ulcers. So diagnosis is by means of culture. You get these Chinese, they're called Chinese character cells. You see the V forms, those are very common in diphtheria. The diphtheroids, the kind of oddly shaped rods, diphtheroids, they can be branched. The organism can be identified by PCR or serology. To grow the organism, you have to use special media. Loeffler's media is the media of choice. Loeffler's media will grow the organism quite well. You can also do tests for the toxin. PCR tests for the presence of the toxin are very good and able to diagnose very quickly. Fortunately, this organism is very susceptible to antibiotics, and the drugs of choice usually are either erythromycin. The organism is also quite susceptible to penicillins. So ampicillin has been used successfully. So has penicillin G or penicillin V. Penicillin resistance popped up in the Soviet Union. So because of that, people are starting to go to more sophisticated antibiotics. Although most strains are still susceptible to your penicillin. And now we come to otitis externa, otitis media, so on and so forth. Otitis externa very often is the result of swimming in dirty water. So if you're kid has gone swimming in dirty water, or if they jam something into their ear canal. That's usually going to be the impetus for causing otitis externa. There are also cases, I was talking to a family physician at church. He said, yeah, these kids got in a wrestling match and the big brother pushed his little brother's head in the dirt and rubbed his ear in the dirt, and he came in, he had otitis externa. Cases like can occur as well. So just be prepared for just about anything. So with otitis externa, you'll have usually ear pain, pruritus or itching of the ear. There's usually some discharge. And if the ear canal, the external auditory meatus is swollen shut, then you might have hearing loss. There's usually be erythema of various parts of the external ear, the tragus. The auricle itself might show signs of erythema. And the ear may be painful when touched. So if you just take the ear and give it a little fold like that, if the child says, ow, particularly if one ear is affected and the other isn't, the other ear is a good control. And then the soreness in the affected ear is a pretty good indication you have a problem. So pneumatic otoscopy will be needed to see if the tympanic membrane is affected. In otitis externa, the otoscopy will detect a swollen and erythematous ear canal. And the erythematous tympanic membrane might be only partially visible. The tympanic membrane is usually mobile with pneumatic insufflation, moving upwards and outwards, respectively. There should be no evidence of middle ear fluid or a perforated tympanic membrane. Perforated tympanic membranes are rare in otitis externa. They're much more common in otitis media. So you will need to begin by removing debris with suction or dry cotton swabs under adequate lighting. If the external ear inflammation appeared over a course of 48 hours to within 3 weeks, and if the tympanic membrane has been preserved in its integrity and mobility, then the diagnosis is pretty well fixed. So to treat external otitis media, something you can have the patient do is to alter the pH of the external auditory meatus by using a 2% acetic acid wash. And then you could relieve the inflammation with topical hydrocortisone drops. Usually 7 days is usually all you need. There are several products you can also use for external auditory meatus in the form of drops. There is a polymyxin, neomycin, hydrocortisone set of drops, 4 drops, 4 times a day. There's also 0.3% ofloxacin. You do 10 drops once a day. The other option is 0.2% ciprofloxacin with 1% hydrocortisone. And in both cases, you treat for 7 to 10 days. If the external auditory meatus is swollen shut, then you need to use a wick. You place a wick in the canal and you put the drops on the wick, and the drops will wick down the wick, will a kind of telephone pole down the wick into the ear. And if there's deep tissue affliction, then you'll want to use oral antibiotics. Now, very often, infections are caused by Pseudomonas aeruginosa. And because of that, your fluoroquinolones are very good for that. So for oral antibiotics, use 500 milligrams of ciprofloxacin. And that'll be twice a day. That will also hit any of your Staph aureus sorts of strains that usually cause otitis externa. If you have a fungal otitis externa, which does happen, then you want to, first of all, clean the ear canal. You can do that then by flushing it with warm water using a bulb syringe. Very easy to do. You can also use saline that you warmed a bit. That way it doesn't give you the shivers when you blow it in. Then you can use a clotrimazole solution, usually 1%. Or you can use something called gentian violet. Do not use these if the tympanic membrane is perforated. If the tympanic membrane is perforated, the only drug you should use is 1% tolnaftate. So these do not use if tympanic membrane is perforated. Same thing with aminoglycosides. Don't use aminoglycosides if the tympanic membrane is perforated. Now, otitis media can be bacterial or viral. And the main culprits with otitis media, and here are some pictures of otitis media. So the main culprits will be Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. So a lot of the same things that caused your other upper respiratory infections as well. Acute otitis media should be suspected if the individual shows inflammatory signs of inflammation secondary to purulent middle ear fluid. And if you have effusion with no signs of inflammation, since the middle ear fluid is in fact serous, acute otitis media will present with ear pain. There might be some hearing loss, usually some ear discharge, and pruritus. There might be also fever, nausea and vomiting, and then signs of upper respiratory infection, cough, shortness of breath. Otitis media with effusion might be asymptomatic, but it might be associated with hearing loss. So pneumatic otoscopy will confirm by showing tympanic involvement. When there's fluid behind the tympanic membrane, you can see bubbles essentially, like what you see here. The bulging tympanic membrane, the marked erythema, and what have you. The bulging tympanic membrane. These are all signs essentially of otitis media. You might also see grayness. So the grayness or whitish discoloration, that's pretty common. So another technique you can use is tympanometry, which will detect middle ear fluid by creating variations of air pressure in the ear canal. And a flattened tracing with low static admittance will indicate middle ear effusion. You can also use acoustic reflectometry, which will measure the sound transmitted and reflected from the middle ear to a microphone located at a probe tip placed against the ear canal. When there's fluid in the middle ear, the tympanic membrane is immobilized and the reduced sound is louder with a narrower spectrum. Acute otitis media often will spontaneously resolve within 1 to 2 weeks. If your patient's younger than 6 months, or for those who are 6 months to 2 years of age, when the diagnosis is fairly certain, then antibiotics are recommended. And essentially, this gives you the percentage of cases of otitis media. Streptococcus pneumoniae, as you can see, tend to cause a more severe otitis media. Group A strep tend to be the case in older children. Anaerobes, not very frequently, will cause otitis media. Pseudomonas is mainly one that causes a chronic, very suppurative otitis media. Enterics will cause it usually very early in life. Beyond that, enterics usually don't cause much otitis media. So here's a treatment for otitis media. Treatment of choice is Augmentin. Augmentin does a really good job of getting into the middle ear. Alternatives include ceftonir, cefpodoxime, or cefuroxime at the indicated dosages. If those don't work, you can continue Augmentin, or you can jack the dose up, or you switch to ceftriaxone. And you do 50 mg per kilogram body weight IM. And if you have a penicillin allergy, use clindamycin or azithromycin. So treat for 7 to 10 days. Usually you want to use a wait and see approach for the first 48 to 72 hours. Persistent middle ear effusion is common after the resolution of the acute symptoms, so expect some effusion usually. So otitis externa, here are the ones that usually cause otitis externa. You can see Pseudomonas aeruginosa is very common because of its association with soil and water. And some people will have a mixed infection. That includes anaerobes. And here's a good picture of an infected ear canal. You can see the erythema looks pretty ugly. And these are the drugs we already talked about for otitis externa. I'll let you review those at your leisure. All right, we talked about viral upper respiratory infections already to some extent. Just keep in mind, treatment is supportive. Treatment is supportive. And here's from your book, the upper respiratory infections and so on and so forth. Okay. Now we get into the lower respiratory infections. And the first one of interest is whooping cough, which is caused by Bordetella pertussis. Bordetella pertussis. Bordetella pertussis will always have a personal interest to me because this organism is responsible for the death of my sister, whom I never met. She died before I was born. Her name was Anna. And I just have seen some pictures of her when she was an infant. I've been to her gravesite. My mother, even in the years before she died, still could not go by Anna's gravesite without weeping. Mom never really talked about her very much. She couldn't without weeping. So I never got to meet her. Hopefully I will meet her in glory someday. But because of this particular organism has been an organism of great personal interest to me. So Bordetella pertussis is a gram-negative rod. It's not an easy organism to grow. It's pretty finicky. So you get it from droplets, of course. And you're going to get it usually from some sort of droplets, usually as a result of coughing, sneezing, sharing breathing space for extended periods of time. The disease has 2 phases. Oh, incidentally, notice the incidence of whooping cough, and then notice how those cases tank as you introduce the vaccine. This is a very nice graph to show to people who tell you that vaccines don't work. And yes, those people still exist. I had a kid tell me, we don't use vaccines because you're putting chemicals in your body. He was very crestfallen to hear that when he ate, he put chemicals in his body. So, all right, so the average incubation period for whooping cough is 7 to 10 days. The range can be anywhere from 6 to 20 days. That's your incubation period. The disease has 3 main stages. First stage is called the catarrhal stage. Catarrhal stage is very similar to an upper respiratory infection with a virus. That's why this disease gets missed. That's why it got missed in my sister. So if you have a mild cough and coryza, we talked about that with measles, inflammation of the mucous membranes. Fever is uncommon, usually low grade, and the cough begins, but it's nothing to write home about. So the cough is going to very gradually progress. In the catarrhal stage, cough doesn't seem like it's any big deal. This lasts 1 to 2 weeks. Then you pass to the paroxysmal stage. So the coughing spells now increase in severity. And I have a recording. So let me play this recording for you of whooping cough. You have a long series of coughs between which there's little or no inspiratory effort. The child usually gags. They start to turn blue. They develop cyanosis. They seem to be struggling for breath. Let's play this movie. You can hear it. You can hear the struggling to breathe, the inability to breathe between the coughs. You usually have sweating episodes. They will occur between the paroxysms of coughing. They're more bothersome at night. And so the forced inspiration that's what causes the kind of whoops. And you heard that, at least I hope you heard it in the movie. And that's where this disease gets its name, whooping coughs. The coughing increases the sensitivity to vomiting. So vomiting also usually becomes an issue as well. This will usually last 2 to 8 weeks. 2 to 8 weeks. Now the organism is able to attach to the respiratory epithelium. Has a variety of adhesins that let it do that. Then when it attaches, it releases several toxins. Those toxins essentially will cause death of the epithelial cells, sloughing. They also activate the cough response. So the cough is actually meant to expel the organism and the debris. But it's a cough that actually causes the cyanosis and the suffocation, ultimately, of the infant. Now, the third stage is the convalescent stage. And the cough in this case will subside, usually several weeks to a month. You may be susceptible to secondary infections. So sometimes in the convalescent stage, because the cough decreases gradually, this stage here might be the stage that actually does you in. So that's something to keep in mind as well. Whooping cough in this country has been almost sent into oblivion, except we have a population of people who don't vaccinate their kids. So you're seeing whooping cough resurgence amongst anti-vaccine groups. The organism is treated usually with macrolides. It's not terribly susceptible to beta-lactams. When you get this kind of coughing, spasms like that, you should always suspect whooping cough, particularly if your kid is not vaccinated. Oh, and diagnosis, the PCR, serology. Serology, there's usually some very good panels for Bordetella pertussis. PCR is very good there are some cases of false positives. So that's something to keep in mind. All right, and that is whooping cough. And it looks to me like we are out of time. So I will either podcast the rest of the pneumonia bit, and then we'll move on to chapter 23. I'm trying to respect the time as much as possible. Please read the case study I sent to you. I will talk about that case study a little bit on Wednesday. In the meantime, if you have any questions, I'll just kind of hang out and answer any questions you might have. Other than that, have a glorious day. I don't know about you two, but it is really cold in this building. They turned the heat down before Thanksgiving, and boy, can you tell. Boy, howdy, it's cold.